Good morning or afternoon. I'm Nikki Boyd, and I am with Fax Healthcare Communications, and I will be your technical producer for today's webinar. The title of today's webinar is Pain Management and Fetal Monitoring. Chasing a Baby Can Start Even Before the Delivery. Before I introduce our moderator, Kaylee Roth, and our speaker, Maria Grosslin, I would like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC or Command-R if you're using a Mac. Please make sure you're not behind a firewall, as this will prevent you from viewing the presentation. I would like to now introduce our moderator, Kaylee Roth. Kaylee was previously on the nursing staff at the University Medical Center in Hammett in the Medical Surgery Oncology Unit in 2017. Kaylee made a transition to labor and delivery in the same institution. In 2022, she took on leadership role on the labor and delivery unit. Kaylee obtained national certification in electronic fetal monitoring. Kaylee, when you're ready, we'll get started.
Thank you, Nikki, for a kind introduction. The title of our webinar today is Pain Management and Fetal Monitoring. Chasing a Baby Can Start Even Before Delivery. Our speaker today is a colleague and highly regarded expert in labor and delivery. Ms. Grosslin is currently the Unit Director of Labor and Delivery and High-Risk Antepartum at UPMC Hammett in Erie, Pennsylvania. She was for several years an ASN clinical instructor at Mercyhurst University in Northeast Pennsylvania. Several of her research interests include increasing patient satisfaction through nursing pain education campaign and reducing primary cesarean section rates. Ms. Grosslin has been very active at her institution as part of several planning committees. Ms. Grosslin has no conflicts of interest associated with this presentation. Just a couple of things to note that we are able to approve 1.0 contact hours of continuing education for this presentation. At the end of the webinar, you can obtain the continuing education credits. The URL will be provided at the conclusion of the webinar. The accreditation statements are listed below, and this activity is supported by an educational grant from Philips. Now I would like to turn over the presentation to my colleague and friend, Ms. Maria Grosslin.
Thank you, Kaylee, for that kind introduction. Good afternoon, everyone. I'm pleased to join you today and talk about pain management along with fetal monitoring and how maybe we're chasing that baby before we've even delivered. Our learning objectives today: upon completion of this educational activity, we hope that you'll be able to explain the options for pain management during labor and describe the effects of pain management on the fetus as seen on fetal monitor tracing. So we're going to start with some basics. Maternal pain management during labor, the going natural term, some things that we do, maternal positioning and movement, taking advantage of gravity, movement, because it can cause changes in the pelvic joints and encourages rotation and descent of that baby. Maybe we're going to use some birthing balls or peanut balls. We've had patients add rhythm and music that can just help somebody relax, and they can just kind of groove along with things that are going. Touch and massage are also great for that natural birthing experience. Perhaps mom and her partner are holding hands, or we're using counter pressure on the back or the hip area. Some other cognitive techniques would include distraction. Maybe we're just watching TV for a while. Other relaxation, deep breathing, anything that helps relax and let the natural process of labor occur. Some other natural ways that we can do this is hydrotherapy. So many rooms have showers. As we know, warm water really promotes relaxation and can decrease pain. It's also easy for the nurse to access monitoring while the patient's in the shower. They can get there and adjust monitors when needed. Many options are for tubs. So tubs that have jetted things in them to just help with that relaxation. It gives a little bit of feeling of weightlessness, which encourages movement and allows, again, for that baby to come on down into the birth canal. When using a tub, we do have to watch for just some things like increased maternal and fetal temperatures. This could cause tachycardia for both mom or the baby. Mom might experience some dizziness or low blood pressures, some weakness and nausea, and we would provide cool liquids and get her back out of the tub. And again, for any of these techniques, we're going to follow your facility's policy. We also have pharmacological options for pain control during labor. We have IV opioids. Some advantages of this would include, cost, ease of availability, and administration. The risks that, as a nurse, that you want to talk to mom about before using them would be that they do cross the placental barrier. There is an effect then on the fetus, and that they have a little bit longer half-life for the baby due to their reduced metabolism. So even though mom might be coming down from those effects, they linger a little bit longer for the baby. Our greatest risk for administering them is if mom would deliver in 2 to 3 hours afterwards. So things that then we would be concerned about is respiratory depression and lower APGARs. Our medication choices would include morphine, which is an opioid, fentanyl, a synthetic opioid, nalbuphine or Nubain, an opioid agonist, antagonist. We do have some cautions for anyone that may experience withdrawal if they have some previous dependency on opioid drugs. And finally, we have an epidural. So an epidural causes a sensory blockade, some loss of motor function. So those of you that may have experienced an epidural yourself or a patient with one, their legs become very heavy, hard to lift them. We're not, up walking around the room anymore. But it does minimize the contraction pain really quite well. And things that we're going to assess on mom is definitely her blood pressure after we've given an epidural. And again, you're going to review your facility epidural policy for any contraindications and patient assessment. So let's talk a little bit about fetal heart rate monitoring. So assessment of the fetal heart rate, the FHR, it's an indirect measure of fetal oxygenation. So things that we have to look at while we're also looking at our fetal heart rate on the screen is, the gestational age, how many weeks is mom, her maternal medical history, any prior fetal assessment results or known anomalies, any medications that mom is on, including pain medications that we might give her, her position, how is she sitting or lying or standing, and also looking at her uterine activity. Is it excessive? Is she having any uterine activity yet? Maybe we're already to the stage where mom is pushing. How is that going to affect our fetal heart rate? And again, we're going to follow facility-specific monitoring policies and provider orders. We do have 2 different types. We could have a little bit more fetal monitoring. It's simultaneous measurement of the fetal heart rate and the uterine activity. So that would be electronic fetal monitoring. So that could be intermittent. That's predefined intervals as ordered by the provider. or continuous. So that's continuous until they deliver, or it's completely discontinued by the provider. So now we're going to begin some case studies. We have two different ones to review for you. The first one is a natural labor. This was a 32-year-old G3P2 at 39 and 2/7 weeks. She came in for an induction of labor. No significant medical history for mom. She had had normal routine prenatal care. The plan was for an induction, so we would start some Pitocin on them. The patient is not planning any pain medications. She did not have any pain medications with her first two and was planning to do it again with the third. And on admission, her vital signs were all within normal limits. So the first look is our admission fetal tracing here. We have a great looking baby on the screen. I know it's a little tough to see sometimes on the strips there, but mom is having moderate variability. She's having accelerations. We're starting to already see some contractions, and she has just arrived for us. So as our tracing continues, we're at, this period is from 6:49 in the morning to about 6:57. We have a baseline of about 135, moderate variability, and an occasional contraction. So the physician comes in to see the patient. It's 7:35. They do a sterile vaginal exam. She's 2 centimeters. The patient requests that the doctor does not break her water. At 7:39, some Pitocin gets started at 4 mUs per hour. At 8:09, her blood pressure is stable at 125/69. Her heart rate is 92. And then at 8:10, she's out of bed to the bathroom where she can ambulate independently. And as you can see on the monitoring strip here, so she's up out of the bathroom. We've put her back on the monitor again. We still have some good variability going on, and mom is having an occasional contraction. So it's now 8:39 on the screen here. We have a baseline of about 140. We have moderate variability, some good XLs. We have a contraction pattern that's starting to become a little bit more consistent, and mom gets up to the bathroom again. Our baby remains active. You can see here at the beginning of this strip of the tracing, baby's kind of missing. There's a little bit, it's broken up. We can't see her as well. But she does have a more consistent contraction pattern starting. At 9:18, we recheck her blood pressure. It's 121/74. Mom's heart rate is 82. Per the protocol, her Pitocin is being increased. The baby's baseline remains between 135 and 140. We have, again, continued moderate variability, and her contractions are starting to be a little bit more regular, around every 2 minutes. On this part of the strip, we can see that the baby is moving in relation to those contractions. We still have some good variability. It looks like we're starting to have an acceleration, and but we don't have a nice, clean, full tracing there. So here, I can't really determine a baseline in this little part because of the majority where she's off the monitor. So at 9:37, the patient requests to get out of the bed to the bathroom again. So we take her off the monitors. And then when she returns to bed, we prep her for a wireless monitoring system. This way she can freely walk around the room. We don't have to take her on and off to go to the bathroom. And that now when she needs to get up to go to the bathroom, it's a lot easier for her. So the wireless monitor is in place now. We can see a baseline of 130. We have great variability, some accelerations going on. There's one little variable decel. She has a beautiful contraction pattern of every 2 minutes. Mom is doing all of the things she's to naturally control her pain levels. She's on the birthing ball. She's ambulating about the room. And as she's doing this, we still have a nice continuous tracing and good variability. We were having accelerations. Mom is in a nice contraction pattern every 1 to 3 minutes. So in just a few minutes at 10:27, Mom is still sitting on the birthing ball. She has a spontaneous rupture of membranes. We can see we have great variability on this tracing, a really nice contraction pattern of 1 to 2 minutes. Mom's heart rate is doing well, hovering between 90 and 100 as she's reacting to those contractions as well. After the patient SROMs, she returns to bed. And let's jump up to 10:44. We do another vag exam. She's 4 centimeters. At 10:50, the patient reports some nausea and vomiting, some increasing pressure. We still have a beautiful baby on here. The variability remains good. Mom's contractions are every 1 to 3 minutes. And 11:01, we're going to do another vaginal exam, and she's now 7 centimeters. At 11:11, we check her cervix again. She's now 9 centimeters. Our baby's heart rate remains around 130, still having that good variability. Maybe we're looking at a little bit of an early decel with that last contraction on the strip. She's contracting every 1 to 2 minutes. And at 11:15, her vag exam shows she's completely dilated at 10 centimeters. The provider comes to the bedside. At 11:16, she begins pushing. And at 11:17, we deliver a viable infant baby girl. She had APGARs of 9 and 9, and she remained with Mom at the bedside. And we are going to jump on to case study number 2. In this case study, we have both opioid and epidural pain management. So we have a 20-year-old G1 P0 at 38 weeks. She's in induction for fetal growth restriction. She's group beta strep positive. We're treating with penicillin. She's had normal prenatal care. The patient is planning an epidural for her pain management. Her vital signs on admission are within normal limits. And at 6 p.m. when the patient arrives, her cervix is closed. We're going to plan for the cervical ripening agent, and the patient is agreeable. So we're going to start right off with her admission tracing. And it looks good. We have a baseline about of 125. We have some nice variability and just a little irritability going on with her contraction pattern. So as we continue looking through her strip here, again, our baseline is still about 125. She's having accelerations, good variability, and again, that just some irritability with contraction patterns. So we're going to jump over to 9:32. Her fetal heart tones are 130. Vital signs are 117 over 66, and Mom's heart rate is 88. At 14:56, the fetal heart tones are 130. Vital signs 111 over 58. Heart rate is 72. And again, the patient is agreeable for cervical ripening again. So we're going to continue on with our fetal monitoring, and she is continuously on the monitors here. We do have an acceleration at the early part of this strip and a baseline of 130. Continuing on, we can see that we have some moderate variability, and we're starting an acceleration at the end, the farthest side of this strip here. We're not really getting much on the uterine activity. It looks like the nurse palpated her abdomen to adjust that tachometer so that we can try to pick up some contraction patterns. And we're at about 9 o'clock at night now. We have what appears to be a very happy baby. We have moderate variability. Our baseline's around 130. She's having accelerations. And we can see, again, still just some irritability, not a good contraction pattern for mom. So at 21:53, the patient is requesting some pain medication. So we gave her 10 milligrams IV of Nubane. We do have some contraction patterns. Mom's cervix is still closed, and we have a baseline for the baby of about 120, min to moderate variability going on here. So we're going to jump ahead a little bit. So we're looking here at about 10 to 20 minutes after the Nubane, and we can see how our effects of that pain medication has made baby a little bit sleepy on the monitor. So we're down to a baseline of 120. We have some minimal variability going on and an occasional contraction. These are typical effects that we're going to see with Nubane. And now we're going to jump ahead. So we're now on to the next day. It's about 10 to 1 in the morning. The patient's contraction pattern is getting much more regular, and she's again requesting some more IV pain medication. We have moderate variability going on, so our baby has come out of that sleep cycle from the pain medication. And again, she is still closed for her cervix, so I'm okay to give some more pain medicine. So jump ahead about an hour after that dose. So we're now on our second dose of Nubane. It doesn't have quite the same effects as the first one did. Our baby is in a sleep cycle here. Again, effects of that pain medication with minimal variability. Baseline is about 120 for that babe. We've taken mom off the monitor here to get her up to the bathroom, and flip to the next screen here. We've gotten her back into bed. She has anesthesia is now at the bedside for us. We have nice vital signs are stable for mom. We have some reassuring characteristics in our tracing. I have good variability. I have an accelerations, and she's contracting right there in that little part of the strip every 1 minute or so. At 2:15, the epidural is started. She was ordered an 8 milliliter initial bolus and then an 8 milliliter per hour continuous rate. Mom's blood pressure at the time is 115/72, and her heart rate is 90. As we can see on this strip here too, our fetal heart rate, we're a baseline about 125. We have min to moderate variability. I see a question on the screen about indications. So let me just explain a little bit about variability. So variability would be how is the baby's heart rate changing? So to say that we have minimal variability, we're at like less than a change of 5 beats. Moderate variability, we're going to see greater than 5 beats over a period of time that we're looking at. So we're essentially, I know you can't see my pointer on the screen, but as I'm looking at the wavy pattern of what that fetal heart rate is doing. Change screens here. So the nurse is still at the bedside. This is just after the epidural has been started. We're going to readjust the fetal monitor here, like so about halfway across the strip that we're looking at here. We're repositioning mom after she's been sitting up for that epidural, readjusting all of the fetal monitors, the TOCO and the ultrasound, wanting to make sure that we can see what's going on here. Again, in the early part of this strip, we see that her baseline is around 120, 125. And we continue with our fetal monitoring here. We have a pulse ox on mom too, so that we have, if you can see, the green line is mom's heart rate, the blue line is baby, bottom are the contractions. And we have a blood pressure here of 127/84. Mom's heart rate is 120. And we do have some, again, min to moderate variability going on with this baby right now. Contraction pattern, still not in a nice consistent contraction pattern, as you can see on the bottom of this tracing. So we're at about 2:30 in the morning. Mom has gotten some penicillin because, as I mentioned, she's beta strep positive. Her SpO2 reading is 100%. She does have an emesis after the epidural is placed. We talked about her blood pressure there. She got some Zofran for nausea, and a recheck again of her blood pressure is 124/78, and her heart rate is 80. All right, so mom is now complaining of pain 6 out of 10. Her cervix is 1 centimeter dilated, and her cervidil has fallen out on its own. We have a nice fetal tracing here. We have some moderate variability going on. That baby looks like it's trying to have some accelerations. We do have a nice contraction pattern about every 1 to 2 minutes going on. Mom's heart rate is staying stable in the 90s. So we have the provider at the bedside. The plan right now is to try some Pitocin. If her dilation does not increase after the Pitocin, we will take a break. They will rest and repeat the cervical ripening. So here you can see we have some minimal variability going on for that baby right now. It's about 7:15 in the morning. Baby could be like in a little sleep cycle going on. This is a common practice. We all like to still be asleep at 7:15 in the morning. So, and we have a baseline for the baby at about 120. Our contraction pattern, not so great here. They're a little sporadic, but we're working on getting into a good pattern. Some nursing documentation. So we had some vital signs and medications. At 7:40, they did start the Pitocin at 4 MUs. And then at 8:10, we increased that to 8. And at 8:13, vital signs were 93/57. Maternal heart rate is 71. And the patient had requested a bolus of her epidural. She needed a little bit more pain medication. She's reporting lower abdominal contraction pain at 5 out of 10. And at 8:16, her blood pressure is 101/58. Heart rate is 83 for mom. At 8:21, her blood pressure is 119/58, and mom's heart rate is 87. The patient is continuing to breathe through her contractions at this time, kind of indicating that she still isn't getting a whole lot of relief out of this epidural. At 8:24, her blood pressure is 123/70, and her heart rate is 82. So the nurse gets the anesthesiologist to the bedside for the patient's continued complaints of pain. And they're now assessing the patient's sensation levels. So we want to make sure that the epidural she has in place is actually offering her good pain relief. We can tell on our fetal monitoring here that we have a beautiful looking baby right now. Our baseline is about 130. We have accelerations, we have moderate variability, we have a contraction pattern of every 1 to 2 minutes. So some good indications why mom would be experiencing some pain. However, we were hoping that her epidural would alleviate that. So after they've done the sensation levels, the anesthesiologist makes a decision that we need to replace the epidural catheter. So the patient is agreeable to this. We can see that in about the middle of the strip tracing here, the patient is sitting up for the epidural placement. She's still having moderate variability. We have an acceleration, and her contraction pattern is every 1 to 2 minutes again. So we have a new epidural that is placed now. Mom's blood pressure is 118/63, and her heart rate is 63. We have min to moderate variability there with a baseline that has dipped a little bit to around 115. And baby falls off the monitor a little bit. Perhaps we're having a decel. It's a little difficult to see towards the later section of this picture. The RN is actually hand holding the monitor, trying to determine what is going on with baby's heart rate. So we are readjusting the monitors. We're readjusting mom. We're trying some of those natural positioning movements that we would use just for somebody who is going without any kind of pain medication. We have the OBGYN notified and coming in to see what is happening here. And what we're noticing is that we're having some new effects from this epidural. So on this portion of the tracing, we can see that we're still have the physician is at the bedside, the nurses remain at the bedside. I have a good tracing for mom's heart rate, but I'm not reading the baby's heart rate very well. What I'm getting is a little spotty. Our baseline has moved down towards 90 after that second epidural catheter is placed. On the right-hand side of your screen, after the second epidural is placed, we have some vital signs for mom. Her heart rate is 63, and again, that blood pressure is 118/63. are adjusting her, we're moving her around, we're hand holding, and at 9:23, we have turned off the Pitocin. So from 9:16, when the second epidural is placed, at 9:23, we've already turned off her Pitocin. The physician is at the bedside. We have put some mom onto the right side. The physician remains at bedside. Anesthesia is also notified and asked to return to the room. Excuse me. Mom's blood pressure at this time is 105/54. Maternal heart rate is 78. The physician remains at the bedside and is now discussing some options with the patient, and the decision is that we should proceed to a C-section based on this fetal heart rate tracing. The patient is agreeable. She consents for an emergency C-section. The patient is then taken off the monitor at 9:27 and is wheeled back to the OR. So very quickly after this second epidural, we can see some pretty serious effects that it had on the baby. Some of the documentation that the physician entered is that they were called to see the patient for fetal bradycardia. They still have her cervix as long and closed, and that the baby is still at -3 position in the pelvis. So that baby is still fairly high. We're not close to it coming down, that we're going to actually have some pressure with the head and the cervix to encourage dilation. Fetal heart rates per her note are down into the 60s without return to baseline despite positioning, giving her fluids, and stopping the Pitocin. And due to the ongoing fetal bradycardia, the consent was obtained for a stat C-section. At 9:33, we had delivery of a viable female. Our APGARs were 7 and 8. The baby did have a nuchal cord ×1, but the infant remained with mom. So we have two completely different cases that we talked about here. I think from the natural labor, and we just had a nice, beautiful tracing the entire time. And with our second, a multiple day induction, we did see some other periods as we review that fetal tracing where the variability might not have been quite as moderate or as good as we would have liked it to be. Some effects of that medication showed some decreases in that variability even more. And then we gave her some new medications. It affected even again. And then finally at the end, we noticed that the second baby had a nuchal cord. So unfortunately, we all know that we can't always see what's happening on the inside to know that that cord was kind of wrapped around the baby's neck, giving it, a little bit of more of a challenge on how we're going to assess our oxygenation and what that can affect the heart rate on. So, but both cases, we had good outcomes, and the infant remained with the mom. So we are going to take some time for some question and answers. I apologize, I might have spoken a little quickly as we moved through some of those tracings, but I hope that we have some great questions that I'd be happy to answer, and Kaylee would also be happy to help us answer those questions.
Thank you, Maria, for the most informative presentation on an important topic. I would like to inform our viewers how to obtain their continuing education credits before we get started with our question and answer. For continuing education credits for nurses and respiratory therapists, this activity has been approved for 1 continuing contact hour. You can obtain those continuing credits by logging on to www.saxtesting.com/BO. You will need to register on the test site, complete the evaluation form, and then upon successful submission, you will be able to print your certificate of completion. This activity is supported by an educational grant from Phillips. For the archived version of this presentation, you'll be able to go online to www.better-outcomes.org. The on-demand version will also be accredited for a continuing education credit. At this time, we will open it up to any questions that anyone may have if you want to put anything into the chat. Let's see, we have a question here from Jake. At what point do we start to worry about fetal bradycardia?
Jake, that's a great question. I think that both Kaylee and I have seen it's almost a little bit provider dependent. And what are our interventions that we have done to maybe eliminate that fetal bradycardia? Have we tried repositioning? Have we tried a fluid bolus? Have we turned Pitocin off if that is running? You know, it's always a good idea to have a second set of eyes come in and check any kind of tracing. But really, fetal bradycardia we really need it to be, Kaylee, correct me, it's greater than 10 minutes of it being in that heart rate zone. So it really is very dependent on your provider and their comfort level and what interventions we've done. Again, what do we know about this baby? Does it have any anomalies or anything going on? What do we know about mom? What is her history? Is she a primip? Is this her first baby? Has she had issues with deliveries before? So there are a lot of things to think of. Kaylee, anything else you'd want to add?
I think, like you said, definitely provider dependent. Like Maria said, you got to try those interventions first. You know, sometimes too, a cervical exam is going to give you a good idea of what's happening, because are we having a episode of fetal bradycardia because our patient just went from 3 centimeters to 10 in 5 minutes, which has happened, and that baby just was like, oh, what's going on? You know, it just kind of it depends on the situation, but if you check that patient and she's still 1 and thick and high, it kind of changes. It can change your game plan. You also want to check to make sure that you don't perhaps have a prolapsed umbilical cord, which can sometimes cause fetal bradycardia. If that umbilical cord drops down through the cervix, if the patient's membranes are ruptured. We here at our facility have one provider that she's very big on 8 minutes. When she hits 8 minutes, that's when in her head she starts thinking about her next moves. So really provider dependent, but obviously, we don't want it to last longer. The longer it lasts, the potential for a adverse outcome. Really good question, Jake. Let's see. Here we have a question from Carla. How many times could you repeat the Cervidil?
So really, I think what I've seen from my own experience as a labor and delivery nurse is twice is the most times I've seen. Honestly, I don't know if there's a maximum number of times that we could use Cervidil, but we kind of have to start looking at why isn't the cervix dilating. So again, maybe mom just doesn't react to this chemical version of our naturally occurring oxytocin. It's just not working for her. Again, what's our gestation? Are we 40 weeks? Are we 37 weeks and we're inducing for preeclampsia. So a lot of different factors on there. Again, but twice I think is the most I've ever seen it. And maybe sometimes we'll switch between using Cervidil. Maybe we've used Cytotec first. So we've used the misoprostol tablets as our cervical ripening agent and then switch to the Cervidil. And then maybe we've had some Pitocin in between. Again, this is a lot of provider preference. We have multiple providers here. So each one does things a little bit differently. Kaylee, I don't know if you've ever seen Cervidil used more than twice.
I can't say that I have. I believe twice is the most that I've ever seen it. And like you said, again, provider preference. Some providers prefer the Cervidil versus the Cytotec. Some think that one works better than the other. And sometimes it is just patient dependent. Some patients respond better to one than the other. That was a really good question. JCal will follow-up question. What is the number that you would consider to be bradycardia that you would start to worry?
So fetal bradycardia is, we're looking at less than 100. So, I know sometimes for myself and different experiences, like maybe that baby just has a lower baseline and I'm not really a fan of it, but it doesn't mean that, that we have bradycardia if we have a fetal tracing that's, hovering right around that 110 area, but less than 100 is, and then again, it's the time that it's spending down there. Good questions.
Good question. All right, next we have, so is our facility now using wireless or for fetal monitoring? It seems much more beneficial for both mom and baby, especially as mom wants to get up and move around or go to the bathroom.
So our facility does have both wireless monitors and wired monitors. So it does have some, again, based on what facility you're at, each monitor has its pros and cons, and the technology that's required in the building for how they each work has an effect on it. I know even just for us, it just depends on where your room is located on the labor floor, how well a wireless monitor works. And again, we have a lot of moms that still kind of want to stay in bed, and we're okay with that as long as they're continuing to move around. The wireless monitors are a great option as well. It just, again, we have some patient preference going on there, what's working best, and ultimately what allows us to trace the baby in the best manner consistently.
Definitely. Let's see. Heidi asks, what is the percentage of pain management used versus no medicine?
That's funny. Kaylee and I were just talking about this earlier. I would say at our facility, and I don't have national statistics for this, but we would say probably 85 to 90% of moms choose pain medication. The majority of that, especially as labor is progressing, are using an epidural. I think it's patient preference. There's a lot of factors that play into that. What I hear a lot of patients say things like, well, my mom did it naturally, so I'm going to try it naturally. Or, if maybe the support person's mom did it naturally, so they want to try to go naturally. But I think we do see a lot of epidural use, especially here, anywhere from 85 to 90%. And then our facility actually offers a combined spinal epidural. So Kaylee, who very conveniently just had a baby about 7 months ago, she actually could tell you about her spinal combined epidural.
Yeah, so I have 3 children. With my first 2, I just had a traditional epidural, the combination of fentanyl and bupivacaine. Worked pretty well. One of the things that I think that we, as like nursing and as providers, need to remind our patients is that epidurals don't necessarily take everything away. It is not a end-all be-all. It's not going to take everything away. You're not going to feel anything, or it's not that you're not going to feel everything. But I definitely had a lot of like right-sided hip pain with both of my children. I do have a history of very fast labor. But so I had experienced a ton of hip pain in my right side with both of my children. So when I went in to go have my third this past fall, one of our anesthesiologists, who is very talented in doing a combined spinal epidural, so he goes more into that spinal space. And you do the medication is still the bupivacaine and fentanyl, but he also does inject fentanyl right into that spinal space. He did that for me, and I have to say, worked so well. Did not experience that hip pain. I had started to during my labor, but once I sat up and got that combined spinal, did not have any pain after, like I had experienced with my previous deliveries. With that going into the spinal space and the fentanyl medication that I had received right into the spinal space definitely had side effects of itching. It did, I think, drop my blood pressure maybe a little bit more than a traditional epidural would. But pain management wise, it was 10 times better than my previous epidurals. And I had thought at the time those were great too. But it's just another interesting route of doing like that epidural. Let's see. Moving on, another question. Do you see lesser need for pain meds with an active or walking moms who remain active during their pregnancies?
I think that, again, is a little bit dependent on the mom, but I love to see moms up walking around. Usually using gravity is a great way to help progress your labor up to delivery. So I would say, again, it kind of comes with what mindset does mom have to start with when she's getting here? Is she really focusing on going without those pain medications? And, are we inducing her? Are we using Pitocin to augment or induce her labor? Are we seeing a completely spontaneous labor and mom is up walking around? But I do think that we can have some beautiful deliveries without pain medication, and those moms, it's really how they have their mindset. We know that everybody's pain tolerance is completely different. How everyone perceives pain, how they manage that pain that they're having is different. So I can't say that necessarily we see less pain medication with ambulating. And again, it kind of depends on what stage of labor they're in while they're doing their ambulating. So are we just at the beginning stages of that labor and they're up walking around? Have we really progressed through and we're, more at the 7-8 centimeter dilated kind of labor? So where are we at with things? But also you guys are having some great questions for us today.
Mm-hmm. There's a lot of them. What other IV pain medications are used besides Nubain? Is Fetal still used? I mean, I think I can kind of answer that. So we definitely have other options of pain medications other than Nubane. Nubane is one of the ones that our facility happens to have. We did for a period use Fetal because there was I believe, a shortage on Nubane. Something that you can also use that one of our providers used frequently was fentanyl. So she would give a dose of fentanyl usually when the patient was like in that 7-8 centimeter mark, just to kind of help get them over that threshold, over that edge to delivery. But those are the most common. Let's see. If a mother decides to change her mind to use an epidural, when is the threshold when she is unable to get it?
That's a good question, and again, it is a little bit dependent on the patient and her cervical exams, and it's always kind of up to the patient if they want to change their mind. That happens all the time, and so if the patient is, I know when working with anesthesiologists, like, is the patient able to physically sit or lie still for the epidural to be placed? We're kind of going by her cervical exam. Are we 8-9 centimeters dilated, which, I mean, they could stay out for quite a while. So again, we have to look at a lot of other signs, like how mom is progressing through labor. We can't rely just on that cervical exam. Is she a primip? Is she a multip? Is this baby number 4? So a lot of things can factor into that. So there's not a hard and set fast time when they can't change their mind anymore. Except maybe if she's like crowning, where I guess that would be our no-go.
Probably at that point she wouldn't want to sit.
Yeah.
Let's see.
Do we think we can squeak in a couple more questions?
Might be able to squeak in one more quick one. I may have missed, what were the causes of abrupt fetal bradycardia? Was it the change of the epidural catheter, anesthesia, actions of the doctor, anesthesiologist? Did we see an abrupt change in the mother as well? I think that's referring to the case study.
So back to the tracing. Yeah. So I think what we really noticed there is that as the anesthesiologist came in to assess the patient's sensation levels, so what our providers do here a lot is they actually use a little baggie of ice, or I've seen them use an alcohol swab. We want to see where mom's actually feeling the differences from that epidural. And it was determined that her first one might not have been placed correctly in the epidural space. So she wasn't getting good pain relief. So then when we did get that baby and that mom some good epidural medication that was actually flowing in there and in the right space, it did take a little drop in her blood pressure for mom. And blood pressure is one of the big indicators that we look at. We want to focus on where mom was to start with, how did it drop. As her blood pressure drops, that changes the effects of the flow through the umbilical cord to that baby. So the perfusion there got changed quite a bit.
Wonderful. I think that's about all the time that we have for questions. Thank you guys for all of your wonderful questions. Thank you guys for attending this webinar. I'm going to turn the presentation back over to Nikki for some concluding remarks.
Thank you very much, guys.
Thank you for attending this webinar. Immediately upon conclusion of this webinar, you will be presented with an online survey. Please keep your web browser open. We do appreciate your feedback. To obtain your CE credits, go to www.saxtesting.com/BO. Register at the site, complete the evaluation to print your certificate. Thank you for joining us.